Hello, everyone, and thank you for joining us here today for another edition of the AJMCtv Peer Exchange video editorial series. Today, we're featuring an expert panel discussion on the advances and integration of the orphan drug class into a dynamic managed care and healthcare environment. Now, specifically, we'll be discussing the implications of an evolving therapeutic landscape for hemophilia and systemic lupus erythematosus, or SLE. My name is Dr. Peter Salgo, and I have the privilege of moderating today's Peer Exchange. And I'm joined by leading experts with a broad spectrum of experience in hemophilia, SLE, and managed care. Dr. Patrick Fogarty, Assistant Professor of Medicine and Director of the Penn Comprehensive Hemophilia and Thrombosis Program at the University of Pennsylvania. Hugh Fatodu, Director of Pharmacy at Johns Hopkins Healthcare. Dr. Maria Lopes, the Chief Medical Officer of CDMI Health. Dr. Michelle Petri, Professor of Medicine and the Director of the Lupus Center at Johns Hopkins University. All right, let's get going. It is estimated that over 7,000 rare diseases have been identified today, affecting over 25 million Americans. Unfortunately, while rare diseases are often chronically debilitating, life-limiting, and in some cases life-threatening, they're still frequently undermanaged and underdiagnosed. Policy and regulatory changes have helped to pave a thriving foundation for further clinical research and development, leading to the development of novel drug agents that utilize genetic and cellular components. Two such rare diseases that have made significant therapeutic headway in recent years are hemophilia and systemic lupus erythematosus, or SLE. However, these rare disorders continue to be therapeutic challenges that are frequently associated with substantial morbidity, mortality, and economic burden. As treatments for these conditions are often very limited, cost prohibitive, and for some simply inaccessible, there are still many significant unmet needs that need to be addressed. And with that, we're going to talk about them. So Hugh, why don't you sort of set the stage? What on earth, by definition, is a rare disease?
Well, in the United States, rare disease is defined as a disease state that affects less than 200,000 people, although that definition is not the same worldwide. The definition in the EU and in parts of Asia are quite different from what we have here in the United States. But here in the United States, again, it's about 200,000 people or less.
And again, we should point out, right, that a rare disease is a statistic. And if you've got it, that statistic is 100% for you.
That is quite true. And even one could say it only affects about 25 million people in the United States. But as you mentioned, if you do have it, it is still, a disease state that one has to live with.
As a doc, the word juxtaposing the words only and 25 million doesn't seem to work for me, but that's why we're here today. What do these rare diseases have in common anyway? Is there a genetic basis to them? What? Help me out here, Marie.
Well, they may not have. The commonality is that they're rare by definition or orphan by definition, and so the general awareness is low. The general awareness by a physician may be low. By the patient, there may not be any family history. So the journey these patients take is often one where they may be misdiagnosed, and frankly, there may not be a lot of treatment options or a treatment per se.
And they're not necessarily mild diseases. I mean, these are significant illnesses, aren't they?
Well, of course, in lupus, the 10-year survival is 90%. And since it's diagnosed often in the early 20s, that's a devastating message to give a young woman.
I mean, that's terrible. And hemophilia, they start perhaps even younger, right?
Well, exactly. And among individuals with severe hemophilia, the condition presents at birth or shortly thereafter, typically.
So, I mean, this begs the question of why is it necessary to recognize these diseases so early? But you might as well put this on the table. That implies we can do things to help, right?
Well, number one, that we can, diagnose, and in the case of hemophilia, can even be diagnosed in utero, prenatally. And that has implications for, what physicians or even patients do with that information. It also has very significant implications for therapy. So where there is a therapy that can be offered, that can be life-saving, that certainly is worth the diagnosis and then considering for treatment options.